Hi, everyone, and thank you so much for joining us today for the Catalyst Center Medicaid 101 webinar. Before we get started, I just want to direct your attention to the Q&A and chat functions of this webinar, which are available at the bottom of your screen. Throughout our presentation, my colleagues and I will be posting resources in the chat. Don't worry if you miss them, we'll share them after the webinar. Please feel free to post questions in the Q&A function, which is also located at the bottom of the screen. We'll be reviewing those questions and providing answers as we go along, and we'll make an effort to answer as many questions as possible during the Q&A session. For any questions we're not able to answer today, we'll post questions and answers to our website along with the webinar recording. We thank you in advance for your engagement. So we're here today to provide foundational knowledge about the importance of Medicaid for children and youth with special healthcare needs, pathways to Medicaid for children, and a key Medicaid benefit for children, EPSDT. Before getting into some apologies. And again, thank you for using the Q&A function to ask your questions. Sorry for a moment. Just welcome again, everyone, for anyone who's still joining us. I just got a notice that says I might have been muted. So just thanks again for using the Q&A function to enter your questions. We're looking forward to responding to what you have to say. So before getting into the content, I'll provide a quick overview of the Catalyst Center and some of our work. The Catalyst Center is the National Center for Health Insurance and Financing for Children and Youth with Special Healthcare Needs. We are located at the Boston University School of Social Work Center for Innovation in Social Work and Health. My name is Rebecca Bilodeau, and I'm the Program Manager for the Catalyst Center. My colleagues are Meg Comeau, Senior Project Director, Allison Boffman, Project Director, and Caroline Parker, Research Assistant. You'll be hearing from Allison later in this presentation, and Meg will be helping us respond to your questions. We are funded by the Health Resources and Services Administration's Maternal and Child Health Bureau to provide technical assistance and support related to National Performance Measure 15, the percent of children ages 0 to 17 who are continuously and adequately insured. While National Performance Measure, or NPM 15, refers to all children, the Catalyst Center's work focuses on children and youth with special healthcare needs. The Maternal and Child Health Bureau defines children and youth with special healthcare needs, or SHCN as we pronounce the acronym, as children who have or are at increased risk for chronic physical, developmental, behavioral, or emotional conditions, and who require more services than children generally. We believe that a system of services, including adequate financing and coverage, that functions well for children and youth with special healthcare needs will function well for all children and adolescents. With that in mind, the overarching goal of the Catalyst Center is to improve healthcare financing and coverage for SHCN. We see this goal as helping to advance two major outcomes: increasing access to healthcare services for SHCN and decreasing financial hardship among families raising SHCN. To accomplish this goal, we provide direct technical assistance about healthcare financing policy, practice, and implementation to state Title V programs, family leader organizations, and other interested parties. We conduct policy research to identify and evaluate financing innovations and share those innovations with other states and stakeholders. We create resources on relevant topics, including briefs, policy explainers, webinars, peer learning opportunities, and tutorials. And finally, we connect those who are interested in working together to address complex financing issues. So before we get further into it, we want to start off with a brief poll to see where everyone is in terms of their knowledge and confidence regarding Medicaid. So I will launch the poll now. We just take a minute. The first is about, has a specific question about the EPSDT benefit. And the other asks you to reflect on how confident you feel in explaining overall pathways to Medicaid enrollment for children. So thank you. I see some folks are participating. I'll leave it open for a little bit longer to give more folks a chance to respond. All right. Great. So it looks like most people have answered, so I'll end the poll and share the results. So it looks like about half say that all children enrolled in Medicaid are eligible for the EPSDT benefit, and a good handful say they are not sure or don't know. We're looking forward to helping share with you and help spread information about this benefit during the course of this webinar. And thank you all so much for your reflections about talking about Medicaid. We're again looking forward to sharing information to hopefully help increase your confidence during the course of today's webinar. All righty. Thank you all again so much for your participation. So just to sort of provide a little bit more context about children and youth with special healthcare needs, according to the 2019 and 2020 combined data set from the National Survey of Children's Health, CHIN represent about 19% of children nationwide. 36.4% of children have public insurance only, which is Medicaid or CHIP, and 8.6% have a combination of public and private insurance. So that makes it about 45% of children and youth with special health care needs who are covered by public insurance, either in whole or in part. Again, according to data from the 2019-2020 National Survey of Children's Health, while 96% of families report that their children and youth with special health care needs are covered by health insurance, 2/3 of families report that the insurance is adequate to meet the needs of their children. In our work at the Catalyst Center, and again, this is following definitions laid out in the National Survey of Children's Health, we focus on the 3 elements of insurance adequacy, and those are that insurance covers needed services, insurance allows children and youth to see needed providers, and that out-of-pocket costs are reasonable. So the main point here is that while many CHIN do have health insurance coverage, about 1/3 of their insurance is not adequate to meet their needs. Among families raising children and youth with special health care needs, family financial hardship is common regardless of insurance status or income level. Catalyst Center analysis has identified 3 primary factors that contribute to financial hardship for families raising CHIN, even when their children have health insurance. The first contributing factor is higher healthcare costs. According to the National Survey of Children's Health, more families raising CHIN than families raising non-CHIN reported difficulty paying for their child's medical bills, and families raising CHIN also reported that their out-of-pocket costs for healthcare were more reasonable less often than families raising non-CHIN. The second factor that contributes to family financial hardship is higher routine expenses. These could include transportation costs related to more frequent medical visits or higher utility bills as a result of running specialized equipment. The final factor is loss of employment income. More families raising CHIN than families raising non-CHIN reported that they had left a job, taken a leave of absence, or cut down on hours worked due to their child's health conditions. According to a recent paper by Foster and co-authors, families that experienced foregone employment, families who were raising CHIN who experienced foregone employment lost an estimated $18,000 in earnings a year. So Medicaid is a public insurance program that is financed through both state and federal funds. As I mentioned before, about 45% of CHIN have public insurance coverage, and Medicaid is the single largest payer of healthcare services for CHIN. This means that depending on the mechanism, changes to Medicaid have the potential to impact almost half of children and youth with special health care needs, making Medicaid a significant component of the system of services for CHIN. Additionally, under federal statute, Medicaid requires little to no cost sharing, that's things such as premiums, co-pays, or co-insurance, for services provided to children. This is particularly important when considering how to address in helping address the high out-of-pocket costs that many families raising CHIN may face. And finally, Medicaid has robust benefits for children. In particular, the Medicaid EPSDT benefit requires all medically necessary services to be covered for children under age 21. So what is EPSDT? EPSDT stands for Early, Periodic, Diagnostic, and Treatment. Periodic refers to checking children's healthcare status at regular, periodic, age-appropriate intervals. You may be familiar with the periodicity schedules published by Bright Futures at the American Academy of Pediatrics, which establishes best practices for screenings and when to perform them. Those screenings, the S in EPSDT, may include physical, mental, developmental, dental, hearing, vision, and other screening tests to detect potential problems. Screening services include an unclothed physical examination, comprehensive health and developmental history, immunizations as recommended by the CDC, and health education and anticipatory guidance. Screenings that fall outside of the typical periodicity schedule must also be covered under EPSDT. Next, for the D, diagnostic or diagnosis. This refers to performing the diagnostic tests that follow up when screening identifies a risk or a potential problem. And finally, the T stands for treatment. EPSDT covers treatment, broadly defined as services to control, correct, or reduce health problems found through early and periodic screening and diagnosis. The overarching goal of EPSDT is to ensure that health problems are identified and addressed early and comprehensively among children enrolled in Medicaid. So again, going back to the beginning, that's the E for early. Early and periodic describe the when of services covered by Medicaid for children, while screening, diagnostic, and treatment are the what. So the EPSDT benefit is pretty significantly different from Medicaid benefits for adults. When it comes to adults, the Medicaid state plan describes what services are covered. State Medicaid programs must cover a federally required set of mandatory benefits and may choose to cover additional optional benefits in their state plans. Under EPSDT, however, any medically necessary service must be covered regardless of whether it's included in the state plan. In general, medically necessary services are those that improve or lessen the impact of a condition, prevent a condition, or cure or restore health. Federal statute does not define medical necessity specifically, and states may establish their own medical necessity definitions as long as they're not more restrictive than the federal statute. And thanks so much, Allison has just put a link in the chat that includes definitions for each state, if you'd like to reference your own state's definition. And states may, as you'll notice in this resource, states may define medical necessity in their Medicaid manuals, administrative code, or using other mechanisms. Depending on the state Medicaid program and the service to be provided, prior authorization is often the mechanism for evaluating medical necessity. In situations where medical necessity determinations are required, they must be assessed on a case-by-case basis. A key takeaway here is that all children and adolescents under age 21 enrolled in Medicaid are eligible for the EPSDT benefit. We'll describe later in this presentation 4 pathways through which children may be eligible for Medicaid. And as you can see, they're summarized in this graphic. Regardless of how a child or young adult is eligible for Medicaid, that is, which pathway led them to enrolling, they're eligible for the EPSDT benefit. And excuse me, I should probably say child or youth or child or adolescent. It's important to note here that there is no EPSDT benefit for children in state health insurance marketplace plans or for children enrolled in separate CHIP programs unless it's specified in the CHIP plan language, which is uncommon. Children enrolled in Medicaid managed care are still entitled to EPSDT. In many states, more and more state Medicaid programs are implementing managed care programs. So whether it's Medicaid fee-for-service or managed care, children are still entitled to EPSDT. Medicaid managed care contracts describe what services MCOs or managed care organizations are responsible for covering. Medicaid MCOs may provide EPSDT services directly, while in other states, the state Medicaid agency may be responsible for services covered under EPSDT that are not included in the EPSDT contract. As the bullet on this slide summarizes, it's all in the contracting and knowing who is responsible for what within that agreement. So federal statute, in addition to outlining the medical services or health services that are covered under EPSDT, federal statute includes several administrative requirements. States must provide education about the EPSDT benefit to families. State Medicaid agencies must help families access services under EPSDT. This can look like helping families with scheduling appointments or coordinating transportation to and from appointments as well. States must also assist in securing uncovered services, particularly those that are provided by state women, infants, and children's or WIC programs, or state Title V programs. And finally, states must also meet specific Medicaid reporting requirements related to EPSDT. They report data about sort of the percentage of children who are reached or participate in the EPSDT program. And so a lot of these requirements are really meant to encourage states to proactively ensure that children enrolled in Medicaid are receiving the benefits under EPSDT that they're entitled to. In a moment, we will transition to describing Medicaid eligibility for children and youth with special health care needs. Some of these eligibility pathways are implemented using different mechanisms within the Medicaid program, so we wanted to provide a brief overview of ways that states can change their Medicaid programs to provide a baseline. The first method is through a state plan amendment. The state plan for Medicaid is an agreement between the state and the federal government that describes how the state designed and will administer its Medicaid program. The state plan also functions as an assurance that the state will adhere to federal rules and claim federal funds for its program activities. You may be familiar with the FMAP, which is the percentage that the federal government will pay to help states run their Medicaid programs. The state plan describes who is eligible for Medicaid coverage, what optional services the state will pay for, and how much providers will be reimbursed. When a state would like to make a change to its Medicaid program and policies, it will submit a state plan amendment to the Centers for Medicare and Medicaid Services for review and approval. States must submit a state plan amendment even if the change in the program is permitted by federal laws and rules. A state plan amendment can apply to eligibility, benefits, provider payments, and other aspects of the program. State plan amendments are permanent, and waiting lists are not permitted for programs established by a state plan amendment. A second mechanism that will be important later in the presentation today are Medicaid waivers. Waivers that are particularly relevant for children and youth with special health care needs, specifically 1915C home and community-based services waivers, will be discussed further on. When a state submits a waiver application, they're requesting permission from the Centers for Medicare and Medicaid Services to waive certain federal requirements. Requests can be made to waive other federal rules such as statewide availability for services, freedom of choice of providers, and universal access to all benefits. A major difference between state plan amendments and waivers is that cost neutrality is required for waivers when they are not required for state plan amendments. For home and community-based services waivers in particular, this means that it must not cost more for beneficiaries to receive care in the community than it would to receive services in an institution. Waiting lists are allowed and are typical for waivers, but waiting lists are not permitted for changes made through a state plan amendment. Waivers are also time limited and must be renewed and approved regularly by the Centers for Medicare and Medicaid Services. So now I will pass it over to Allison, who will describe different pathways to Medicaid for children.
Thanks so much, Rebecca. Thank you for that great content and getting us started. So it's really fitting that we talk in some detail and explain the pathways to Medicaid for children because of some of the things that Rebecca mentioned. Medicaid is a really important source of healthcare coverage for children in general, but particularly for children and youth with special healthcare needs. Medicaid does provide the EPSDT benefit, which is really the most robust benefit that children can find in healthcare coverage right now. Certainly important for all kids, but particularly important for children and youth with special healthcare needs to have that robust benefit available to them. So this slide lists the 4 general pathways by which children are eligible for and can enroll in Medicaid coverage. And just to reiterate something that Rebecca said, once a child is eligible for and enrolls in Medicaid, regardless of the pathway or the doorway by which they enter Medicaid, they are entitled to receive the full scope of benefits under the Medicaid state plan, including the EPSDT benefit. I'll talk about each pathway a little in the slides that follow, but the 4 pathways are income alone, income and disability, severe disability, or institutional level of care, and foster care. Next slide, please. So path 1 is eligibility based on income alone. So this pathway does not need to incorporate the health status of the individual or the child at all. It's basically based on the family's income or the individual's income if we're talking about someone who's over the age of 18. Although originally Medicaid was available only to children and families that were receiving welfare cash assistance, over the years, Congress expanded eligibility for children based on income. And it's always written in the criteria as a percentage of federal poverty level, or FPL. And as a result of these expansions, states were required to cover at a minimum children and infants up to age 6 in families with incomes up to 133% of FPL, and older children up to 100% FPL. And that all changed in 2010 with the passage of the Affordable Care Act, which aligned the mandatory minimum Medicaid eligibility level to be 130% of FPL for children of all ages. So the minimum eligibility level for Medicaid as a percent of FPL, as we know it, 138%, is a floor. So it's something that states can certainly create their own income level criteria around, but they're not allowed to go below that percent of FPL, 138%, as a rule. And while the minimum floor for children's income eligibility is currently 138% of FPL, we know that the median across the states, so half of the states are above this income level and half the states are below. The median eligibility limit for income across the states is 255%. So that lets us know that in general, states are setting their income criteria for Medicaid quite a bit more liberally than the minimum standard that they're held to by federal law. According to the National Survey of Children's Health 2019 and 2020 data, about 44% of CHN live in families who reported that their household income was lower than 200% of the federal poverty line. So many CHN, therefore, are eligible for and enroll in Medicaid based on income eligibility alone, regardless of what their health status might be. Next slide, please. So path 2 is eligibility based on income and disability. And this pathway basically covers two different elements. One is related to supplemental security income, and another is related to a newer state opportunity through the Family Opportunity Act, which I'll talk about. So children can be eligible for Medicaid coverage based on income and functional level of disability. This pathway to Medicaid coverage primarily relates to low-income children with functional limitations who receive support through the Supplemental Security Income Program, or SSI. And SSI is a federal income support program that provides cash payments to help meet the basic needs of children who have a mental or physical disability. For SSI, children must meet the Social Security definition of disability to be eligible. In most, but not all states, an individual who receives SSI is automatically eligible for Medicaid. So two things I want to emphasize here is that this pathway is based on income, so targeting low-income children, and it's also based on the definition of functional disability by the Social Security Administration. So in order to be to qualify through this pathway, you have to be eligible for the Supplemental Security Income Program based on disability and also income level. So there are some children, some CHN in families that would qualify for Social Security, Supplemental Security Income, for SSI based on their functional disability, but the family income is too high. And this is where we we come in with this new opportunity for families. So there was an opportunity established in 2005 through the Family Opportunity Act for these families to buy Medicaid coverage. And I'll talk more about the Family Opportunity Act and this new state option on the next slide. Great. So the Family Opportunity Act was passed as part of the 2005 Deficit Reduction Act. And this federal legislation created an option that allows states to offer families who are over income to, like I said, to buy into the Medicaid program on behalf of their child who meets functional disability criteria. And this is an option for families if the state implements it, regardless of whether or not they have private insurance. So clearly an advantage of this option for states and for families is that it allows parents to continue working, maintain their private insurance coverage without sacrificing the health and well-being of their child with a special healthcare need, functional disability. So you can see families can buy into Medicaid coverage for a child with a functional level of disability to have full Medicaid coverage if there is no other source of insurance. They can also supplement the commercial insurance or private insurance that they may have for the child. And this is particularly important because of that robust EPSDT benefit that Medicaid offers that other private and commercial state federal marketplace plans do not tend to offer. To date, very few states have elected to implement this option. There are about 5 states that do it. And I'll talk a little bit more about the details on this slide here. So the provisions of this state option through the Family Opportunity Act are that the family income has to be below 300% of the federal poverty level. And the table on the slide that is presented shows what those 300% federal poverty level guidelines are for 2022. The federal poverty guidelines change every year. It's important to note here that the 300% of FPL that's noted is refers to an adjusted gross income, and the adjustments that adjusted gross income refers to are adjustments made by the state to their state context. So when you're looking at the table or referring to the table, the income levels for 300% FPL are not hard and fast at the state level. Like most things within Medicaid, states have quite a bit of flexibility to how they design and implement their programs. So for this example, states will adjust the gross income around 300% of federal poverty level to set their criteria for these buy-in programs. The FPL level that we show here is really set in federal legislation as a requirement for states to receive the federal match that Rebecca mentioned, otherwise known as the FMAP. So states have the freedom to set income levels above 300% of FPL for Medicaid buy-in programs, but above 300% of the federal poverty line, they do not receive federal matching funds. So the incentive naturally is for states to sort of keep their criteria there as well. States are allowed to charge premiums for this this program, a Medicaid buy-in program, and premiums vary by state, and they also vary by household income. According to the federal legislation, premiums for families whose income is less than 200% of FPL can be up to 5% of the adjusted gross income. So the premium that the state sets for the Medicaid buy-in program can be up to 5% of adjusted gross income if the family's household income is less than 200% of FPL. If the family's income is between 200% and 300% of FPL, the premium that the state charges can be up to 7.5% of the adjusted gross income. So the third point that we want to make related to Medicaid buy-in programs is, as we saw on the last slide, states can offer these type of programs to help families supplement their private and commercial insurance. And that saves Medicaid a lot of money and also provides benefits to families and their children. And states can provide, as part of a Medicaid buy-in program, premium assistance to help these families maintain their private coverage. So states can also offer to help families pay their commercial insurance premiums in order to help maintain that coverage. Next slide, please. So on to pathway number 3. Pathway number 3, I want to do some contrasting with pathway number 2 when we get there. This path is eligibility for Medicaid based on severe disability, or what sometimes is called an institutional level of care criteria. And there are two main aspects to this pathway. One is a state plan option that is known as TEFRA, and Katie Beckett, and the other are home and community-based service waivers, which Rebecca introduced us to. Most often 1915C, home and community-based service waivers. So I'll talk about TEFRA first, and then I'll talk a little bit about home and community-based service waivers. So the TEFRA state plan option is actually an extension of a waiver that Congress created for a girl named Katie Beckett. Katie was a 3-year-old girl. Many of you know Katie's story very well, and the story of the advocacy delivered by her mom. So Katie was a 3-year-old girl who was born completely normal, contracted encephalitis, which is a viral brain infection, when she was 5 months old. And Katie was in the hospital with this viral brain infection when she had a seizure and went into severe respiratory distress. Another seizure hours later sent her into a coma and on life support. And at this point, the virus attacked her central nervous system and paralyzed her diaphragm, which permanently affected her ability to breathe on her own and swallow on her own. And in the beginning, Katie's parents had private health insurance, and the private health insurance covered all of the medical expenses and hospitalization due to the encephalitis. But during her extended hospitalization, she became eligible for Medicaid. When the Becketts reached their cap on their private insurance, Medicaid began covering Katie's care. Katie spent 3 years in the hospital, and then her condition improved to the point where she was able to be discharged. And her parents wanted to bring her home. And at the time, Medicaid would not pay for the care that Katie needed if she were cared for at home. But Medicaid would pay for the care that Katie needed if she was discharged to a nursing home or if she remained in the hospital. So Katie's mother advocated and advocated very strongly for Katie to be allowed to remain covered by Medicaid and for Medicaid to pay for her care at home. And she was successful in her advocacy and got the attention of her policymakers in the state of Iowa where they lived, and eventually President Ronald Reagan. And Congress created a waiver just for Katie to allow her to be to continue to be enrolled in Medicaid, even though she was not being cared for in an institution, and Katie got to come home. So TEFRA is another name for the Tax Equity and Fiscal Responsibility Act of 1982. And Katie's waiver through Congress was, I believe, issued in 1981. And in 1982, through the Tax Equity and Fiscal Responsibility Act of 1982, as Congress created a state plan option that was basically an extension of the waiver that Congress created for Katie, but it is a state plan option. And this state plan option allows children like Katie, children who would otherwise be institutionalized or hospitalized due to the complexity of their medical needs, to be cared for at home and maintain Medicaid eligibility. And it does this primarily by disregarding the parent's income in that eligibility consideration. So I want to contrast this with the income and eligibility pathway in the sense that the institutional level of care criteria are usually decided on by the states versus the SSI income and functional disability pathway. The functional disability criteria are set at the federal level and usually by the Supplemental Security Income Program, the SSI program criteria for functional disability. Now, so this pathway basically allows children that require an institutional level of care because of their medical needs and health needs to, instead of being cared for in an institution, which Medicaid used to be the only thing they paid for, to now be covered by Medicaid and receive their care at home and in the community. So another option for this pathway to Medicaid is through home and community-based services waivers. TEFRA, as I mentioned, is a state plan option, so has all the characteristics of a state plan option, does not need to be cost neutral, has to apply to statewide and cannot have a waiting list. Home and community-based services, 1915C waivers, on the other hand, can be targeted. They can have waiting lists, and they can have other special elements that the state decides to carve into them. But they are similar to TEFRA as a pathway because they target the same types of SHCN. HCBS waivers, on the other hand, can also provide additional supports, depending on what the waiver specifies, depending on how the state puts it together. Additional supports written into waiver programs can be supports like respite, could be home and vehicle modifications, it could be other types of services in the community that help children receive their care in home and in the community. Okay. Next slide, please. And then the final pathway is not really a pathway, but more like a category, and that is foster care. So all children in foster care are automatically eligible for and enrolled in Medicaid, whether or not they have a chronic health condition. So across the board. But we do know that children in foster care are more likely to have a special health care need, especially if you utilize and think about children and youth with special health care needs using the Maternal Child Health Bureau's definition as we do, where all children in foster care either have or are at risk of having a special health care need. So certainly we would consider all children in foster care to be be in that at-risk category if they don't have a diagnosed special health care need already. Next slide, please. So in hopes of being helpful, we've made a sort of a comparison chart for all of you to compare the 4 pathways in terms of 3 different elements. And those elements are found in the first column on the left-hand side, income limits, whether or not functional level of disability is part of the criteria, and whether or not institutional level of care is part of the criteria. So just to summarize, the 4 pathways in terms of this table are the first column, income alone. We've mentioned how the floor for that income level, which varies by state, or the floor doesn't vary by state, but the income level criteria vary by state. The floor for that income level is 138% of FPL. Most states have set their criteria much higher than that. The second pathway comprises the 2 columns, SSI and FOA buy-ins. So there are, we talked about how there are income criteria for this pathway. Income criteria for SSI is very, very low. Income criteria for states who have implemented Medicaid buy-in programs is much higher, includes much higher income families. There are functional level of disability criteria for each of these. Definitely functional level of disability criteria for this second pathway, income and disability. But not criteria related to institutional level of care. Then TEFRA and HCBS waivers are pathway 3, where regardless of income, so there are no income criteria for this pathway, but the main criteria is whether or not the child or youth meets the institutional level of care. And then the final pathway that we mentioned is foster care, where there are no income criteria, no functional level of disability criteria, and no institutional level of care criteria. Basically, every child enrolled in foster care is eligible for the state Medicaid program where they are. So hopefully that table helps to put things in perspective a little bit. And by all means, we'd love to have you put your questions in the Q&A function. Next slide, please. All right. So I want to talk very briefly again about Medicaid managed care because it's become increasingly important for CHN, just as Rebecca mentioned. State Medicaid agencies are increasingly providing services to children and youth with special health care needs through Medicaid managed care delivery systems. So what is a Medicaid managed care model? Medicaid managed care is a type of healthcare delivery system, and it's organized in such a way to lend itself towards certain outcomes. And those outcomes include managing cost, managing utilization of services, and maintaining quality. Quality is a really important aspect of Medicaid managed care models. Within a Medicaid managed care arrangement, entities, so managed care entities, are paid usually a per member or a set rate that's called a capitated rate by the state Medicaid agency. So you have an entity, they're paid a set rate by the state Medicaid agency to run the program and to pay providers for the care of people enrolled in that Medicaid managed care program. CHN, whoever, more and more people enrolled in these programs are CHN, but they can be anyone. Medicaid managed care models vary by state, just as Medicaid programs vary a lot by state. They Medicaid managed care models don't always require contracting with a managed care organization. They can be slightly smaller than that or different than that. Some Medicaid managed care models focus primarily on primary care case management. Some include specialty care services. There's a very wide range of variety that you can have. But the key is that entities are paid by the state Medicaid agency to run the program, provide the care. They're paid a set rate, and then they pay providers for the services that they render. So next slide, please. All right. So a few data points about Medicaid managed care organizations and CHN specifically. Medicaid managed care as a healthcare delivery system model might be slightly different, but these are data points focusing on Medicaid managed care organizations themselves. So as of July 2021, 41 states, including the District of Columbia, had state Medicaid agencies that had contracts with Medicaid managed care organizations. And as of July 2020, 38 states enrolled CHN in specific Medicaid managed care organizations. One thing to point out about managed care organizations and CHN under Medicaid is that many of these organizations provide what we call enabling services to their members, which can be very important for CHN, including care coordination services to enrollees. Next slide, please. Okay, so it's time for the poll again. So pull out your responses to the poll at the beginning of the webinar if you have written them down. Let me see. I'm going to pull up the poll. All right, so the questions are the same. Don't forget to scroll down so you answer both of the questions. So who's eligible for the EPSDT benefit in Medicaid? And question number 2. I'll give everyone time to answer. Okay, I'll wait a few more seconds. All right, response is slowing down, so I'm going to go ahead and end the poll, share the results. So wonderful job. Over 90% of you answered question 1 correctly. Who's eligible for the EPSDT benefit in Medicaid? All children enrolled in Medicaid, regardless of how they get to Medicaid. They all receive the EPSDT benefit under the age of 21. So that benefit ends at age 21. And great, we've got some folks feeling confident that they can explain the pathways to Medicaid, which is great for us to see. Okay, I'll stop sharing. Oops. Okay, and we go to the next slide, please. Thanks, Rebecca. So for the EPSDT benefit, states, as usual, are allowed to have a say. So they're able to say whether it stops before age, up to age 21 or including age 21. And Meg, please correct me with whatever I'm getting wrong here. So hopefully you might want to learn even more about state Medicaid programs. and as they relate to children and youth with special health care needs, or other populations maybe that you care about. So two really nice resources that we wanted to highlight for you. The first is a Medicaid Learning Lab webinar series hosted by Georgetown Center for Children and Families. I will say it's not meant to be SHCN focused, so it does cover Medicaid programs in general at the state level, but they have webinars on all kinds of different subjects. And they're continuing this series, so I really recommend that you check it out. And the Catalyst Center has more information about Medicaid and CHIP in our tutorial called Public Insurance Programs and Children with Special Health Care Needs, a tutorial on the basics of Medicaid and the Children's Health Insurance Program. So feel free to check out both of those resources as well. So I have not been paying attention to the Q&A function or the chat very much, but thanks, Rebecca, for doing that. But we're going to open it up for some questions right now. And see, we have some great questions. I think I'm just going to go in order. We've got less than 10 minutes. So the first question I think is from Megan, who asks, how will the pending Medicaid, quote unquote, I'm using your quotes, Megan, Medicaid purge impact children? I think you're referring, Megan, to the end of the public health emergency. So I invite Rebecca and Meg, my colleagues at the Catalyst Center, to chime in. One thing I'll say is we are not sure how it's going to impact children. What we do know is during the public health emergency, states were offered an increase in the federal matching funds that they normally get for running their state Medicaid programs. But in order to receive those funds, they had to commit to what were called Medicaid maintenance of effort requirements. And one of those requirements was that the state is not allowed to disenroll anyone from Medicaid during the public health emergency. So basically what will happen at the end of the public health emergency and what states are preparing for now is state Medicaid agencies are going to need to redetermine everyone's eligibility. There are people who were eligible for Medicaid during the public health emergency because of an income change or for other reasons that may not continue to be eligible. And those that's important for states to determine, but it's also important for states to not let people fall through the cracks, which is, I think, one of the concerns, especially around children and youth with special health care needs. One of the ways people tend to fall through the cracks is by notices and letters from Medicaid related to redetermination being lost in the mail or being unanswered for a number of different reasons. So there's a lot of emphasis by a lot of different players, ourselves, Georgetown Center for Children and Families, Lucille Packard Foundation, I'm sure Kaiser Family Foundation has written about this. There's a lot of information out there about helping states prepare for the end of the public health emergency. The expected timeline I can share about. So we're pretty sure it's the public health emergency right now ends July 15th, but everyone's pretty confident that that is going to be extended because the Biden administration was committed to telling states 60 days in advance if they were not going to extend it, and that did not happen. So the public health emergency is very, very likely to be extended on July 15th or right before then, and the public health emergency will be good for another 90 days. So that takes us into October. I will also give a quick plug to something Rebecca probably already put in the chat, which is a website we have on the Catalyst Center that has very well curated resources related to the end of the public health emergency. Center for Medicare and Medicaid Services is putting out a lot of really good information. They really want to help states prepare for that as well. Okay. Great, I'm just looking through some of the questions. As Rebecca said, if we don't get to questions we will try to answer in the Q&A document. Oh, some of these are really good, but I would prefer, they're very complicated, which is not surprising because state Medicaid programs can be very complicated. So I'll say this last question I'm intrigued by from Elizabeth. What is the definition of care coordination provided by Medicaid managed care? Great question. I think it varies quite a bit. I think the best place to look for what care coordination means for Medicaid managed care organization is in the contract. Or in the member handbook, in the provider handbook. Basically, it can mean whatever is able to be written into the contract. And I want to give Meg a chance to add her 2 cents as well, and Rebecca.
Mm-hmm. So I think you're spot on. Allison, I hope you can hear me. If you can, give me a thumbs up.
Yes.
Great, thank you. I think you're spot on with regard to there being different definitions of care coordination used by different Medicaid programs and different Medicaid managed care programs. Sometimes the definition of care coordination that's being used is not necessarily what people might assume is care coordination. So I would definitely take the term care coordination sort of on its face and dig down into what the actual definition is that's being used by either the managed care company or the Medicaid program. Sometimes it's targeted case management, sometimes it's utilization management, sometimes it's care management. There are all kinds of different terms that are used, and they're used in different ways. And so your comment that it's all in the contracting is a really good cue that folks should dive down into that a little bit more deeply and not make assumptions about what it means. If I'm recalling correctly, our friends and colleagues at the National Academy for State Health Policy, or NASHP, put out a very good brief on Medicaid managed care and definitions of care coordination. So I would suggest that you all take a look at their website. We will include a link to that document in the Q&A that we send out after. So you don't have to go on a wild goose chase, but if it's something that you need to know this afternoon, then I would suggest taking a look at that NASHP document. Thanks.
Thank you so much, Meg. Yeah, I think we've highlighted a few NASHP resources during the webinar, and they are a great source of information. I want to thank you all for joining the webinar and for completing the post-webinar evaluation. I know Rebecca's put the link in the chat. The evaluation should also pop up when the webinar ends today. Thank you for completing that so we can better understand your needs and continue to produce helpful and quality resources. You can visit our website at catalystctr.org to learn more about the Catalyst Center or access resources related to Medicaid. We will be posting a recording of the webinar as well as the question and answer. So thank you again for attending and have a great day.